So today I will discuss about HIV in the CNS, mainly the HIV Associated Neurocognitive Disorder. I like it that you actually did a poll early during the session so that we know that a lot of people have not heard of this malady. This is very, very important. It's an eye-opener also for me because, of course, I deal mostly with academics in UP and in the Department of Neurology who are quite aware already of this condition called HIV-associated neurocognitive disorder. We always screen our HIV patients for this. So sometimes you really, really need to screen. So I suggest let's put in a tool so that we can follow them up over the years. So let's see. Let's move on, Rad. Can we have the next slide? Rad. Oh, so you have to move on because I think they already took that test. And I hope everybody will ace that test. Kate, do we have time to discuss the answers later? I
Yes.
hope so.
Actually, ma'am, magpo-post test sila. So, hindi tayo mag-discuss.
Okay. Okay, that would be great. So anyway, in the pathogenesis of HIV in the CNS, once a person is infected, the HIV is detected very early in the primary infection. In fact, it's a very high viral load in early neuroinvasion. Next slide, please. What happens is a direct and indirect mechanism of activation. Next slide, Rad. Rad. Thank you. So, the blood-brain barrier is actually not very effective in containing the HIV virus. We all know that it's very avid. It's a fan of neurons. No? Talagang it has an affinity for the central nervous system. So, it will get through, it will pass through. And it infects the macrophages, it infects the astrocytes, it infects the microglia. And not only by direct invasion does it induce an inflammatory response. In return, there are a lot of chemokines, cytokines, and neurotoxic factors that are released, and all of them contribute very synergistically to neuronal cell death. Talagang patay ng patay ang ating mga neurons. Pakonti lang siya ng pakonti because of this neuroinflammation. Next, please. Okay, so by direct infection, it can infect your microglia. It produces the cytokines that eventually also affect your astrocytes. No? But by indirectly shedding the GP120 protein, it also affects the uninfected microglia. So much so that there is a lot of calcium that is released, a lot of glutamate. Again, neurotoxic factors that lead to neuronal death. Next, please. So what are the symptoms of increased ICP? Why did I jump into this? Now, this is very important, especially in the first case that was discussed in the theoretical cases. What the patient was having is actually signs of increased ICP or swelling of the brain. No? Why? Patient has headache, the patient can have double vision or diplopia, the patient can have agitation or restlessness, there could be a lot of nausea and vomiting, and eventually decreased sensorium. So these are things to watch out for, not in patients with HIV. Our first things to think about when we see patients like this is they are having an infection. Next, please. So what kind of infection often afflicts them? A lot, no? But the warning signs here are present. You can see fever, obviously. Patient is drowsy or even sometimes stuporous. No? The patient has a lot of papilla edema or swelling of the blood vessels of the eye or the optic disc, and they have nuchal rigidity, no? Yung neck nila matigas, no? So what we call meningitic signs. Next, please. So you have to do a full neurologic examination. It's available online if the UP College of Medicine has some videos on this. If you want to do it properly, meron din po naman pong shortcut if you only have 5 minutes. But what is important is to take note of the mental status changes, no? From a drowsiness to inattention to eventual coma. No? So you have to do this neurologic exam. You have to check for the pupils. You have to check for the fundus if you can. No? And you always check for meningeal signs. Next, please. Next, please. Okay, so these are the usual suspects that we see in HIV cases who are admitted in the hospital for increased intracranial pressure. The usual suspect being TB, no? Tuberculous meningitis or TB in the CNS. No? We often also see fungal meningitis in the form of cryptococcal meningitis. And between TB and cryptococcal meningitis, the signs and symptoms could be the same. So only a lumbar tap and analysis of the cerebrospinal fluid can tell us which is the difference. No? And also, toxoplasmosis, no, is very, very common. It invades the CNS. So the top three that we often see in PGH are often tuberculous meningitis, cryptococcal meningitis, and toxoplasmosis. Next, please. But even if we see this usual parade of suspects, there are also unusual suspects. Next, please. Rad. Thank you. So on the left, oh, sorry, not. Okay, so on the left is progressive multifocal leukoencephalopathy. No? We hardly see this anymore, but with the HIV pandemic, if you call it, then we already start seeing them. It's actually a viral infection. And this patient I saw, only 35 years old, HIV positive, presenting with a lot of seizures, cognitive decline, and motor deterioration, turns out to be positive for the JC virus. So this is a PML. No? And on the right is a CNS lymphoma. You might say, what is a tumor doing in a patient with HIV? Well, immunocompromised patients and immune deficient patients can have a triggering of tumor mechanisms, and that is why they are also prone to central nervous system lymphoma. Next, please. So those are the unusual and usual suspects. So what if there is no clear infection, meaning you did your lumbar tap and you weren't able to identify any organism? Could HIV be enough to cause all of this? Next, please. So the answer obviously is yes. No? There is what we call the HIV Associated Neurocognitive Disorder. And before 1991, when we were not very aware of it, we used to call it the AIDS dementia complex. No? But there have been many efforts through the years to classify and subclassify. So I will not belabor you with all the classifications in the past. Let's move on to the next slide so that I can show you the most recent classification. Okay, so sorry, I will introduce first. You might be wondering what is HIV-associated neurocognitive disorder and why we call it a neurocognitive disorder and not just dementia per se. This is in keeping with DSM-5, which classifies neurocognitive disorder as either minor or major. A minor being having a little effect on your daily activities or functionality, and major meaning there are already things that you cannot do because of a memory problem. No? So HIV-associated neurocognitive disorder is a spectrum of impairments associated with the HIV infection in the central nervous system. The prevalence and severity increases as the disease progresses. So the values are varied from 20 to 60%, depends on who's testing and what tool is actually being used to test. And this occurs even with proper antiretroviral therapy. Neurocognitive status is determined based on their performance, usually on neuropsychological tests. You might have the impression that these are very complicated tests, but no. I will teach you many tools that you can easily access and actually do on our patients. So this slide is courtesy of Dr. Katindi, who's also a neurologist working in Jose Reyes Hospital. Next, please. So why is this important for us? Because it lowers medication adherence. So they forget to take their medications. And because they are impaired, they have a worse quality of life and they will have difficulty obtaining employment, and it shortens their survival time. Next, please. So this is the spectrum that I'm talking to you about. No, majority will be asymptomatic, meaning only if you test them, you see there is a little bit of a problem or they are quite slow, but nevertheless they can carry on with their activities of daily living. A lot will also be lumped in the mild neurocognitive disorder, and some, less than 15%, will be in the HIV associated dementia category, meaning they would need help in doing their daily activities. Next, please. So in the asymptomatic neurocognitive impairment, make sure that there is no evidence of a pre-existing cause or any other infection at the moment. No? This cognitive impairment does not interfere with activities of daily living. And when you test them formally, there are more than one standard deviation below the mean in the domains of memory, attention, language, or they can be just slow when you test them, but they can pass some of the tests that you actually give them. Next, please. The next is the mild neurocognitive disorder. No? It only mildly interferes with their activities of daily living. They can still hold on to their job as long as it does not depend on the domain wherein they have difficulty with. For example, they can still do office jobs, but they can be slow. Or if they used to be very, very good in math, they're a little normal now. So they're basically not very efficient at work, but they can still carry on. They are still very independent, especially in things that they need to do at home and in terms of social function. So they're still basically independent, but higher ordered things they might have difficulty with. Next, please. The next, of course, is the HIV associated dementia. No? This gives them a marked interference in activities of daily living. They will need help in carrying out activities of daily living, especially in taking their medications, in handling their finances, sometimes even in taking public transportation. They would need guidance and assistance. They would need reminders for their appointments and follow up because they have difficulty in learning new information, and they're also slow with information processing, and their attention span could be defective. Next, please. So hand is very common. It affects 1 in 5 individuals living with HIV. Next, please. So let's look at regional data. In the Asia Pacific region, an estimated 1 million are at risk for developing HIV-associated neurocognitive disorder. No? So this cross-sectional study estimated 12% of patients already have significantly impaired cognition. No? Even the studies from India actually quote a higher number because their screening tool was always positive. So it depends. It depends. And the viral classifications are also very important because the more neurovirulent it is, obviously, the more HIV-associated neurocognitive disorder you expect. Next, please. So how about in a tertiary hospital in the Philippines? So this was a study that we conducted in the University of the Philippines, Philippine General Hospital, no? Where they get their medications monthly. So we screened them for HIV-associated neurocognitive disorder, and the prevalence was pegged at 40%. No? Almost 40% of these were actually asymptomatic. We only got the neurocognitive impairment because we tested for them. Half of them only had mild neurocognitive disorder, and the remaining 8.7% already had HIV-associated dementia. Remember, these are the patients na masipag mag-follow up, masipag kumuha ng gamot nila. No? It could be way worse for those who are lost to follow up. Next, please. So that was the prevalence that we got, around 40%, and impairments mainly in the domains of memory and executive function was what was most significant. Next, please. In a bigger study, in in a bigger study conducted in the Jose Reyes Hospital, the prevalence was at 65.9%. No? So, and they didn't differ much in terms of their age, sex, or years of formal education. Next, please. So what was actually important for them was actually their CD4 count. No? So cognitive impairment was significantly associated with a low CD4 count. And they also had a higher anxiety scores using the neuropsych inventory in patients who were tested but without cognitive impairment. So their conclusion is that neurocognitive impairment is very common in the HIV positive Filipino patient. Next, please. So what do you actually ask in your patient encounter? Uh, the best things to ask for are, do you experience memory loss? Makakalimutin ba kayo sa mga events, sa mga nangyari recently, sa mga appointment nyo, kung anong date na ngayon? Or do you feel that you are slower when you are reasoning, planning activities, or solving problems? Napakabagal nyo ba mag-isip or nahirapan mag-concentrate? Do you have difficulties paying attention in a conversation? Can you complete a book or can you actually complete watching a movie? And basically, may problema ba? Do you have problems in handling money, in keeping track of your medications, in traveling, using public transportation from place to place, and even using the telephone or the cell phone? Those are very good questions to ask for you to be able to peg what is their actual functionality. Next, please. So next is now that you know, for example, they tested, yes. So these are some suggestions for tools that you can actually use at the bedside for screening. Now, you can use the mini mental state examination. You can use the English version if your patient is bilingual. There is a Filipino version that's adapted, and then there is also the Montreal Cognitive Assessment Test. There is an English and Filipino version. These are available online for free up to now. And there is also the HIV Dementia Scale, which is quite easy actually. Next, please. Right, okay. So the International HIV Dementia Scale is very easy. So you just tell the patient, we will test your memory. So now I will give you 4 words to recall. So take 1 second to say each. So you say dog, hat, bean, red. Then you ask the patient to repeat all the 4 words. Now, they don't have to be in order, but they have to be able to repeat the 4 words. If they are not able to repeat the 4 words, you cannot ask it later. So they have to be able to repeat the 4 words. So you give them time to memorize it. So after they said that, you can move on to the next, but you will tell the patient that you will ask for it again a bit later. Okay. And then in the motor speed, so determine if your patient uses the right or the left hand to write. For example, me, I'm right-handed, so my non-dominant hand is the left. So put the hand on the table, the left hand on the table, and then ask them to tap the thumb and the forefinger alternately and as quickly as possible. And then you have to count how many taps they can do in 5 seconds. So if there's a scoring, so if they're able to do 15 taps in 5 seconds, then that's a 4. So this the grading is there accordingly. Next, please. So that is to test the motor speed. And then next is you test their psychomotor speed. So on the bottom right, you can see the fist, palm, and edge. It is a sequence of things that you ask the patient to do. Again, using the non-dominant hand, or for my case, my left hand. So I make a fist, a palm, and an edge, and I do it repeatedly. So you have to count how many sequences the patient can do properly in 10 seconds. No? If they are able to do 4 sequences in 10 seconds, it's actually a perfect score. Next, please. So now is the time for you to ask them to recall the 4 words. I wonder if you recalled the 4 words without looking at the slide. So it's dog, hat, bean, and red. So you give them 1 point for each word that is spontaneously recalled. No? If you give them clues or cues, then hindi siya, it's called prompting. No? You don't give them one whole point for that. And then at the end, this is when you score. Then you score them. If they are perfect, the maximum score is 12. No? A patient who is scoring 10 or less should be evaluated further for possible dementia. Next, please. So remember that these patients also have a lot of comorbidities. No? They may be co-infected with hepatitis C. They can have a lot of emotional and behavioral disturbances. They have pressures from their family. They may have other neurological diseases. Pain and neuropathy is a reality for HIV patients, and also drug and alcohol abuse. Next, please. So treatment, this is very sad because we don't have exact treatments for it. No? We have tried acetylcholinesterase inhibitors for these patients, but they are not very effective. No? Only slight symptomatic improvement are seen in a small trial. Acetylcholinesterase inhibitors are medications that we give for patients with Alzheimer dementia. No? So hindi siya masyadong effective. No? So there are no treatment, there are no current treatment guidelines for this. Next, please. So sabihin nyo, why do we need to know about this if we can't treat it? But well, we have to be hopeful. We still have to screen them because there are things that we can advise them, especially when they are in the early part wherein they're asymptomatic or they only have mild neurocognitive disorders. So these are future treatments very much under investigation. Most of the trials are trial failures. Next, please. So I think we could focus more on the patients who are still asymptomatic or only those who are mildly impaired. No? We can ask them to build up their cognitive reserve. No? Tall words, no cognitive reserve. Liken your brain and your neuronal synapses to a tree. So there on the left, I have a tree with very few stems and branches, and on the right, I have a very healthy tree. So that's what we want to do. No, that's what we want our brain to become. We want it we want it to become a very organized and tree with all the leaves and all the branches. How can you do this? You have to exercise. So you have to tell your patient there is no excuse not to exercise. Exercise makes the blood flow and it brings substances to your brain, and it also flushes out toxins from your brain. No? Even if they have a significant amount of illness or debilitation, there are still things that they can do to increase their level of activity. And aside from physical activity or exercise, they can also engage in healthy conversation and learning activities. They may be online or they can be with healthy chats with family and friends. Next, please. This cognitive reserve is what you need so that when the brain starts deteriorating because of neuroinflammation and viral infection, then you have things to fall, parang you have reserve. No? It's like the streets in Metro Manila, kung marami kang shortcut, then you can use them in times when the major roads are blocked. Other ways to improve cognitive reserve include playing a musical instrument, having games, board games, or other games with friends. You can have pets. You can talk to them. You can interact with other pet owners. And daily walks are very, very important. And you should always be open to new learning. Being open to new learning is something that is what we call a lifelong learning activity, and it will really improve your cognitive reserve. Next, please. So key messages: neurocognitive ability is impaired in most patients with HIV. Majority might be mild or asymptomatic. Severe dementia rarely develops in patients on effective or combined antiretroviral therapy. So if you saw in the PGH study, it was like 8%. only. So mababa naman siya because these are on patients on follow-up with adequate therapy. Most patients with MND are clinically stable, and comorbid disorders contribute to neurocognitive impairment but do not also fully explain it. Next, please. So oftentimes you need to do neuroimaging and cerebrospinal fluid studies to make sure that no obvious or usual suspects are there in terms of CNS infection. No? Although HIV therapy is necessary, sometimes they're not really sufficient to avert cognitive impairment. And hence, you have to make sure that they will invest in their cognitive reserve and brain health. No? So treatment to address neuroinflammation and cardiovascular risks seem to be a more rational approach. And for me, in our setting, in our country, asking the patients to build their cognitive reserve may be a better treatment option. Next, please. I think that's the end of it.